All right, this is where I left off. I think I don't know where we're at, 6 or 7. I should be writing this down. Okay, remember, this was the last slide. We were preventing attacks and dealing with pain. Now, the diet for a patient who's got chronic pancreatitis is going to be bland, high calorie, 3,000, 6,000 calories, high carbs, high protein, low fat. 50 grams of fat, you're trying to control the diarrhea. You can increase the fat to, 100, 150 as the diarrhea subsides. The patient's going to get pancreatic enzyme replacement, things like pancreatin, pancreolipase. These are tablets that have amylase, lipase, and trypsin in them. They need to take these tablets with their meals in order to have the enzyme available to digest the food. Control diabetes. And here the control of diabetes is going to be insulin. Surgery. Surgery can be done. It's not a primary treatment, but it can be done to relieve chronic intractable pain, to help facilitate drainage of the pancreatic duct, to cut out a part of the pancreas that's diseased. All right, that's chronic pancreatitis. Now let's talk about pancreatic cancer. This is not a good cancer to have. 30,000 people are diagnosed every year. In cancer deaths, it is the 4th leading cause. It is more common in men, more common in African Americans than Caucasians. Smoking is the most firmly established risk factor. Cause is unknown. There are associations with chronic pancreatitis, cirrhosis, and diabetes. There are associations with coffee, alcohol, and a high-fat diet, but the only firmly established risk factor is cigarette smoking. More than half the tumors are going to be located in the head of the pancreas. So as that tumor grows, the common bile duct becomes obstructed and the patient becomes jaundiced. It tends to extend early into surrounding structures, particularly the liver and the regional lymph nodes. If the tumor starts in either the body or the tail, it's silent until it's very advanced. Most of the time, your pancreatic cancers have metastasized at the time of diagnosis. A pancreatic cancer that's found early is usually found because something else is going on, something unrelated, and there's something incidentally found on a CAT scan, and then they start investigating. But most of the time, it's a late diagnosis with a horrible prognosis. X-rays don't help. CEA is a carcinoembryonic antigen. That's going to be elevated in 80 to 90% of patients. You might have elevations of amylase and lipase. Now, an abrupt onset of diabetes is an early sign of pancreatic cancer in 25% of patients. But that's 75% of patients that don't have that. The alkaline phosphatase can be elevated. It's either common bile duct obstruction or liver metastasis. When ALK-Phos is elevated, the bilirubin is elevated, and you have an obstructive jaundice, that indicates the obstructive nature of this tumor. A CAT scan is going to provide a good overall assessment, but again, by the time you see this on a CAT scan, by the time you're doing a CAT scan, because your patient has some symptom, typically jaundice, it's too late. The ERCP is your best diagnostic test. You see obstruction or narrowing of the major ducts, and you can get specimens for cytology. The manifestations, they might be similar to chronic pancreatitis. You might have a deep-seated abdominal pain where laying down flat makes it more uncomfortable. Sitting upright, flexing your spine, flexing your left thigh, that can help with the pain. The patient may present with an unrelenting obstructive jaundice and along with that, of course, the clay-colored stools, because the bile isn't getting into the GI tract. There's weight loss that's rapid and progressive. In 20% of cases, there's a palpable mass. It's almost always surgically incurable. If the liver is enlarged, that's going to indicate metastasis. Migratory Thrombophlebitis. Think about what that means. Migratory means moving, and thrombophlebitis is inflammation of blood vessels. That happens in about 10% of the cases. But migratory thrombophlebitis can also happen in patients who have other kinds of malignancies. So it's not specific for pancreatic cancer. Okay, now, there is a surgical procedure called a radical pancreatoduodenectomy, called the Whipple procedure for short. The procedure is really only justified if all of the gross tumor can be removed, if it's not invading your adjacent lymph nodes, liver, and areas near major blood vessels. About 15%, that's 1/5, of cancers of the head of the pancreas can be resected. That's not a big number, okay? But it's seldom possible if the cancer originates in the body or the tail, because by the time you have any awareness at all, there is distant metastasis. What they do with this surgical procedure is they take the proximal pancreas and they cut it out. Okay, so basically, if you look at this picture here, everything in gray gets removed. The proximal pancreas, the adjoining duodenum, the distal part of the stomach, the distal piece of the common bile duct, and then you take the pancreatic duct, the common bile duct, and the stomach, and you anastomose them to the jejunum. So all this stuff in gray, everything in gray gets cut out, and then you just stick stuff together again. Here's your stomach. It gets stuck here, and then your pancreas gets attached. That's a dead pouch now. Gets attached here to reestablish pancreatic juice flow. It is a radical procedure, okay? Again, a lot of times they'll open the patient up and they'll look in there and then they'll close them up and they won't do anything because it's just too involved. Radiation is effective for pain relief, but it does not improve survival. Chemotherapy has extremely limited success. Most patients are going to die within a year of diagnosis. Overall, 5-year survival is only 10%. Your goal of quality is going to assist the patient to have as much quality of life as possible. If there's a surgical procedure, you're going to do post-op care, including the care of drains and stuff like that. So that is it for your pancreas. Please jot down your questions as you work through this content. And I am giving some consideration to doing some of Lesson Plan 16 yet today. But I don't have it with me, so we'll see how it goes. I will work on getting this posted. Catch you later.